coming today. Welcome to Evergreen Wellness Live. I'm super excited that you're here. Thank you for sharing your time with us today. It's going to be a great show. I want to introduce myself. My name is Cheryl Parrish. I'm the CEO of Evergreen Wellness. And Evergreen Wellness is a resource for people 55 and over to take really bite-sized steps toward wellness, and not just physical or medical wellness, but all kinds of wellness. It's holistic in nature, so from social health to spiritual health to financial health and all the different things in between. Evergreen Wellness is your resource for taking a step toward being more well. And so Evergreen Wellness launched in the Villages a little bit less than a year ago. We are proud to say that we're partnering with the Villages Health in their efforts to help make the Villages America's healthiest hometown. So again, thank you for being here today. We're going to have some fun with our Villages doctors who are presenting today. And so what I'd like you to do here in the live audience or also at home, please take out your smartphones. And if you would, I'm going to have you send a text that will allow you to participate in our live polling during the show. So first, if you would please, in the to line, the top line where you would normally put your friend's name, please type in 22333. Okay? And then in the bottom part where you would type your message, please put EGWL. And it doesn't matter if it's uppercase or lowercase, just EGWL for Evergreen Wellness Live. And you should get a confirmation that indicates that you're set up for the live polling. Okay, so thank you. So today we're very pleased to say that we have two doctors with us from the Villages Health, Dr. Robert Reilly and Dr. J. Derek Thompson. These two gentlemen have been kind enough to share their time with us, and so I'm going to go ahead and introduce you first to Dr. Reilly. Hey, Dr. Reilly. Thank you for coming.
Thank you for having me.
Dr. Reilly did his undergraduate work at Notre Dame University. Medical school, he went to the State University of New York at Stony Brook School of Medicine. You have to be pretty smart to be able to remember all that.
You can just say SUNY, State University.
Okay.
SUNY. Works.
And he is currently the medical director at the Creekside Care Center. He's been with the Villages Health for 4 years, and we're just absolutely pleased to have him here today. Thank you, Dr. Reilly. And Dr. Thompson?
Hey, dude.
Thank you for being with us. Appreciate it. Dr. Thompson did his undergraduate work at Georgia Southern University. He went to med school at the Medical College of Georgia, and he recently joined the Villages Health Specialty Care Group. He's a urologist and has been practicing for many years. Most recently, he did 5 years practicing in both Ocala and the Villages, so he's pretty well known around here. So the Villages Health is absolutely thrilled to have you on board, and just excited. So thank you so much. Okay, so before we get started with our presentation, we're actually going to do a question using your smartphones and do some online polling. So the first question is, how would you characterize your level of decision making when it comes to your health care? How would you characterize your level of decision making when it comes to your health care? Please type only the letter that corresponds to the answer. So either A, B, C, D, or E. Those are your answers. So A, I follow the doctor's orders no matter what. B, I lean on my spouse or family members for advice. C, I always want to get a second opinion. D, I feel my doctor and I are equally engaged in decision making. Or E, I trust myself when it comes to what's best for me. So live audience, studio audience, at home, all audiences, please go ahead and put in your answers. Look at this, guys. It looks like we got someone taking the lead here with I feel my doctor and I are equally engaged in decision making. Well, they must be patients of the Villages Health. So why don't you guys use this as a launching point and go ahead and let's do some talking.
Sounds good.
All right, thank you.
Thanks, Cheryl. So welcome. It's great to have you guys here. Spend a little time with us on this beautiful afternoon. Appreciate you giving us some of your time and attention. So based on that poll there, I think you guys may have either heard this talk once before, or like Cheryl said, you're part of our practice already. We're here to talk today a little bit about this idea of what we call shared decision making. Before I get into that, by show of hands, how many of you here would say you believe you have a pretty good relationship with your primary care physician, or your doctor? So. A good number, which is really good. How many of you would say that you understand what the idea of shared decision making, what it means? Not as many. All right. Well, you kind of might, more than you know, because based on your answers, you're kind of onto something there. So this shared decision making, and one last question for you. How many of you here understand what a patient-centered healthcare model means, or what does that mean, patient-centered healthcare? Anybody understand what that means? Okay. Once again, though, the fact that you're here, and the fact that a lot of you already go perhaps to see our docs at Villages Health, you kind of maybe already seeing what a patient-centered model looks like. So take a step back. Basically, healthcare is really changing. I know my parents' generation and their parents' generation, when they would go to the doctor and sit down and go over whatever they would go over, I think that the model may have been largely one of, here's what the doctor says, this is what I'm going to do, and what doctor says, patient does. And it used to just be that sort of unidirectional, top-down, I'm going to tell you what you should think and what you should do. And that was one way to do things. That was one way to affect healthcare. Over time, things have changed. We're much more aware in medicine that there's more of an art to what we do than there is science. I mean, there's a lot of science, and we spend a lot of time and money learning that science, and we always are still learning, but there's an art to it, and there's often more than one right answer to any decision. Sometimes there's no right answer, and sometimes there are different options that you can choose from. And the more that we recognize that, the more I think we understand this idea of what we call shared decision-making. So shared decision-making, quite literally, is one of the premises of a patient-centered healthcare model, which basically means that we put the patient in the middle of everything that we do, everything that we decide, everything that we construct, whether it's the layout of our care centers, whether it's the design of our staff, how we arrange our call schedules, how we run lab tests. It's all designed around the patient. Keep the patient in the middle of every decision, and everything branches out from there. Well, really nothing is more aligned with patient-centeredness than shared decision-making. Shared decision-making, like it sounds, is making a decision that is together. It's a decision that you as the patient ultimately are making with the doctor navigating. And I always use the analogy with my patients of we're in the car and you're driving and I'm riding shotgun and we're going on this trip together. And it's no more that I'm driving and you're in the back seat and I'm going to let you off where you need to get to. So difference, it has changed. And so what's the upside of doing it that way? Why? Why shouldn't we just go back to like when my grandparents were at the doctor and they just said, take this and don't ask any questions and I'll see you in a month? Because by and large, that doesn't always work. We know there's data out there that says that doctors prescribe a lot of medications that never get filled, never get taken the way they're supposed to get taken. Patients will nod in agreement while you're sitting there with them, and they will promptly go home and put that prescription in the drawer. When they come back in a month and their blood pressure isn't changed, and you're sitting there wondering, why? Didn't this medication work? And they didn't take it. Well, why? Because they don't understand why. What's this for? What's the side effects? Are there other alternatives? Can I go naturally without medication? All of that. But if you're in a practice in which you're seeing patients rapid fire and have to get through your day, in a non-patient centered model, you're just there to kind of give care and move on. And at Villages Health, we don't do it that way. We pride ourselves that we go another direction. And that's with this shared decision-making model. So we know if we look at the data from decisions that are made in a shared model, A, they're far more likely to carry through. The patient's far more likely to actually go through with the decision made. B, the patient understands their health a whole lot better when they're engaged in this kind of model, because by virtue of the fact that you're being asked to really take the lead in the decision, you have to understand it. You have to understand your health care and why are we even having this conversation and why does a decision even need to be made. In addition, you understand the upside and the downside. You understand the pros and the cons of what are all the decisions involved. And really, shared decision making is very important because, quite frankly, a lot of the decisions in healthcare don't have a singular answer, as I said earlier. A lot of times there's potential harm in certain tests, in certain treatments, in certain screening tests we do. And so we need to understand that. Patients need to understand that before they decide to go down that road, that actually there may be some harms that may outweigh the benefits. And it may change depending on the situation. Now, probably the single best example in the current world that we live in medicine regarding shared decision making is, and this is a example, but I have a colleague expert here in the subject to help me along here, is this idea of prostate cancer screening. And we have some women in the audience, but women have spouses and women have dads and women have grandparents, and so they need to understand this too, because this is a disease that affects men, of course, because men have prostate glands, women do not, but women are involved just as much because they're right there, alongside that significant other. So prostate cancer screening has been around for a long, long time, as Dr. Thompson can speak to, and it is a prime example of this idea of shared decision making. So with that, I'll turn it over to Dr. Thompson just for some background on prostate cancer screening.
Thank you very much. Thank you, Dr. Reilly. Prostate cancer in men is the most common cancer diagnosed, and it has been evolving over the years in how we handle prostate cancer. The U.S. Preventative Service Task Force in 2013 came out with guidelines. They were totally unfavorable for PSA screening, and recently guidelines have been reintroduced, which kind of changed things around just a little bit of tweak, and it really enforces this idea of a patient-doctor interaction in the decision-making process. And basically the guidelines for men age 55 to 69 now encourage you to talk to your physician about, should I obtain a PSA test, which is a blood test, or should I not obtain a PSA test? And the physician role is basically to help you understand that diagnosis of prostate cancer has good points and it has bad points. Prostate cancer may be overtreated because many prostate cancers you live with, and they will not affect your quality of life from day one to the day you die. And the beauty of prostate cancer screening is that it may be able to help us pick out that small population of patients which their cancer is very significant and will impact their life, either through metastatic disease where their bones are involved and they may develop something like a fracture of their hip, or it may result in their death. So weighing the risk and the benefits in that decision in that group, 55 to 69, and looking at evidence-based medicine is very important in making your decision. In the 70-year-old, the evidence does not support PSA testing at this point. So talking to that primary care physician and getting their understanding and enforcing your opinion and whether or not you feel like you want to know what your PSA is, know what my risks are, should I do it or should I not? That is a give and take relationship, and if you trust your primary care physician, which we hope all your patients do, it can be a very good thing for you to engage in. So, Rob, that's
Sure.
the background with that.
Thank you. And we're fortunate where I work. I'm fortunate to have colleagues like Dr. Thompson who kind of get that concept of patient-centered care, shared decision making, building a good relationship with your primary physician, because just based on what he just said, it's confusing, right? I mean, if you're between this age and this age, maybe you should, maybe you shouldn't. If you're after this age, the data's not really there. It's confusing to me. I mean, and I read and I try to absorb the guidelines get updated seemingly all the time, and when I see that, I kind of always think that when the target moves so much, then probably nobody really knows what it's supposed to be yet. So it is all the more important that you have the opportunity to have a good relationship with your primary doctor where you can actually sit down and not only have a relationship, but have time in the office. I used to say at the bedside, but we're not in the hospital. Sitting down in the office to actually say, okay, here's what we know. What do you think? And have that conversation. And it is very individualized. It is high stakes because we know, often I'll get patients will say, well, what's the big deal? It's just a blood test. I'll say, well, you're right. Just going to get in your blood. Get my blood anyway. Can't you just put the PSA on there? Yes. But you need to understand, because when it comes back, we are now going down a rabbit hole together. And that rabbit hole leads to things. You may end up with Dr. Thompson with a biopsy. If you understand that, and you understand the risks and the benefits of all of those things that may come, yes, the PSA is a singular blood test, true. But what comes from it, I think is very important. And in many ways, it was one of these things that PSAs used to just be tacked on to your cholesterol and your kidney test and your sugar test, and there's the PSA. And it was high, off you went to the urologist, and then, then you down that rabbit hole. And that rabbit hole is appropriate for some people. That's a hole that you're going to go down. In some cases, given your age, given your other health conditions, it might be the right thing to do. But then there are for some people where it may not be. And so again, coming back to this whole idea of putting the patient, putting you in the middle of the conversation, and then going around and figuring out together, what the next steps are. So,
prostate cancer has evolved in its treatment. It used to be, almost everybody got surgery. You had prostate cancer, no matter what. You were off to the OR and you had your prostate removed. And complications from prostate surgery can be significant. There's anywhere from a 10 to 60% chance of urinary incontinence, which means you're going to be using pads in your undershorts the rest of your life. There's a 10 to 50% chance, and even higher in some series, of erectile dysfunction. So it's a trade-off. Do I want to take the chance of having one of those complications, weigh that against actual possible cure of the disease? So you really want to know, and to Rob's point, when you engage and you get that PSA, you want to know, okay, this PSA, am I going to do something about it? Suppose it's high. Do I really want to undergo those prostate biopsies? Prostate biopsies themselves can be associated with some issues. You do have bleeding. You can have some pain. 1% of all people that have prostate biopsies end up in the hospital with infection. So it's not just a totally benign procedure. Most of the time it's easy. Most of the time it's done without any problems. But there are pluses and minuses to everything that we do. So the goal of actually a PSA and what we're trying to find is we're trying to find that subset of people that have that high-risk disease. And we have certain parameters that we use. Rob has had his discussion with his patient, and that patient decides he wants to go see a urologist. Then we're going to talk about what his PSA is. We may want to do a couple of other studies, a couple of other blood tests to actually correlate, and even a few math calculations to correlate exactly, is that PSA significant to that particular prostate? Because PSA may vary with inflammation in the prostate. It may vary with the weight of the prostate gland. And we can kind of narrow this down a little bit and say, is this a significant risk? Should we engage in a prostate biopsy and go forward to that next step? So our goal is to find that subset of people in which that prostate cancer is going to impact their life. And that's the beauty of PSA test. So when you do the PSA, you got to be engaged in it. You want to know. I feel it's important in that subset of people, but there are risks.
And I think I agree totally, and I think that the main thing, this is an example. The talk is about shared decision making, but we have a prime example of what that looks like when you're talking about prostate cancer and PSA screening. But there are many examples. I mean, in women, mammograms. When do you stop? When do you start? How often? I mean, what about colonoscopies? When do we start? When do we stop? How often? The list goes on and on. I mean, which treatment? You got 10 different drugs that we can pick from. And again, all of these have at the core of them all a good, solid, foundational relationship between you and your primary doctor. Because without that, you're kind of operating in a sea of knowledge that's all over the place. Dr. Google, as I like to call him, who gives sometimes really bad information. Sometimes it's okay. Google's wonderful. We all love it. But when it comes to health decisions, it's not always the right place to go. And unfortunately, for some patients that don't have the opportunity that I hope many of you have, coming to our care centers to see our doctors, and others like it. And I'm biased because I work for Villages Health, but any system in which you've got a patient-centered approach where you've got time with your doctor and where they really care and have that relationship with you, you will be successful. You will be successful. So, how are we on time, Cheryl?
And speaking of technologies like Google and other online technologies, let's do another poll.
Sure.
I think that'll be kind of fun. So again, if you would pull out your cell phones. The question this time is, and now I realize that we have men and women in the audience, as the doctor stated earlier, so just pretend you're a guy for a moment, but or pretend it's, they're talking about a loved one, a male loved one. Your doctor says your PSA test result came back elevated. What's your next step? What is your next step? Is it A, I don't believe the test, I want to repeat it? Is it B, I want an immediate referral to a urologist? Or is it C, I want to talk to my doctor about it? What's your next step? Well, doctors, it looks like they've been listening.
I think so. And some of them really like Dr. Thompson. So.
Yes, yes.
Like you better.
Do you want to talk a little bit about that response, or do you want to?
I'm excited for that
Yeah,
response
yeah.
because I think, and I mean, based on the initial poll question, it seemed like you guys were already clued into what I believe, what we both believe is the right way to make any of your healthcare decisions, even as minor as they may seem. Having that foundational, strong, solid relationship with your primary doctor. I mean, if when it comes to PSA testing or whatever it is, when you have that fork in the road, you got to take it, like Yogi Berra said. Come the fork in the road, take it. We got to go somewhere with this, and but it's not necessarily to a procedure. It's not necessarily to a biopsy. It's not. It might be the right thing to do. But there are other options, and understanding you have those other options, and that applies to whether it's a PSA test or any other thing, is so critical, because no matter what happens, you have really been able to make what we call an informed decision based upon your values, based upon where you're at in your life. And as I said earlier, there are far fewer right answers than there are many possible answers for pretty much everything we do in healthcare. So this is good to see.
Dr. Thompson, would you add anything to that?
Well, my job is basically to provide answers for his patients, and to relook at this from just another viewpoint, as I would see it from my experience with my patients.
Let's talk about answer B, though, because we had, a fair, almost 20%. I want an immediate referral to a urologist. How do you guys feel about that response?
Well, it's understandable because, right, exactly. And I have some patients who that would be their that has been their answer. I've got my PSA came back and it's 6.5, and last year was 3, and so that's a big jump. And what's going on? I want to talk to Dr. Thompson. And that is okay. There is nothing wrong with that. But I always want to make sure that we have at least had the conversation about these are your options that you can pick from. A lot of times not putting the pressure on to make the decision right then and there. Somebody has a PSA elevation, their immediate thought goes to, oh my gosh, I got cancer. But understanding that there are a lot of things that elevate your PSA that aren't cancerous, as Dr. Thompson was alluding to. You can have infections, you can have inflammation in your prostate gland. Maybe this is a blip, maybe this is not a trend, and but it's understandable answer, that 20% of folks would say that because, I've got something, I want it fixed. And that's an understandable answer. And it's okay, and that may be the right answer, but it's at least the conversation needs to happen. And so there's nothing wrong with that answer. But
okay, very good. So live audience, why don't we open it up to questions? This whole concept of
shared decision.
shared decision. Thank you. I couldn't
No
think of the
problem.
word. I was thinking patient-centered.
It's a little
Shared
bit of a mouth.
decision.
Yeah, that's a whole.
What questions do you have? Let me come back to you.
What are the symptoms of prostate cancer? Like, what can you first tell? Is it the PSA test, or is it something different? Can you tell if it's not that?
Good question. Most people have no symptoms of prostate cancer. The most common thing that we see as men with our prostate are signs of obstruction. So as the prostate grows as you age, you have more and more difficulty evacuating your bladder. You can get infection, like we've talked about, in the prostate, and that'll draw your attention to the area quite quickly. But prostate cancer, unless it's late in the course, in which it may cause obstruction or bleeding, generally is completely asymptomatic. So in the old days, it was the rectal examination where we felt a little knot on your prostate. But oftentimes, it may be too late when you actually start palpating the nodule. And a large percentage of patients way back there 30 years ago were being found out they had prostate cancer when they went to the ER with a pathologic fracture of their hip. Because prostate cancer, of course, metastasizes to the bones quite frequently in the late course. So PSA has a definite role, but prostate cancer in and of itself, especially in the early stages like we're concerned about, is silent.
That's a great question, and I totally agree. And just to kind of broaden it out to, screening for a lot of cancers, the idea is you catch it before it's symptomatic. So, i.e., colonoscopies, mammograms for women. The hallmark of a truly good screening test is that it screens out things that are not cancer, finds with a high degree of certainty stuff that is likely cancer, and gets it before it becomes a problem. And that's why if you look at the number of types of cancers out there versus the number of screening tests that we actually do, it's really there's only a few certain things that it is highly recommended you get screened for as far as cancers go. And that's, again, breast cancer, colon cancer, and prostate being more controversial, but those are the ones for which we've got testing, And again, the reason that those have the tests they have is because they've been shown that if caught early, they're treatable, curable, And so it's a very good point. But in general, and that's, again, a whole other thing where you talk about shared decision making is what screening tests should I be having? When should I stop having them? All of that. So good question.
Other questions?
Is it genetically, is it something that you can get passed down to your kids from your parents, or is it something any guy can get?
Good question again. There is a subset of prostate cancer that is genetic. Approximately 10% of all prostate cancers are genetic. And in the guidelines, people that have a first-degree relative with prostate cancer probably at a little bit more higher risk. So those screening numbers probably should come down a little bit. There's been no real definitive evidence-based testing, but if you look at people that are higher risk, certainly those people that have first-degree relatives that have prostate cancer certainly deserve a hard look. And personally, I would drop the screen down a little bit in those guys and be a little bit more aggressive.
If you're not in a patient-centered system, patient-centered healthcare system, how do you have that conversation with your doctor when you just have a few minutes with them and you know that this is a conversation that's going to take 30, 40 minutes?
It's a great question. Well, first of all, I would highly recommend you get into a patient-centered system. But no, in all seriousness, it's a great question because a lot of patients are, and it's not that I tout ourselves as we care about our patients and no other doctors do, not at all. It's just that some systems are designed with you in mind first, so therefore appointments are bumped out longer. There are fewer of them. I have fewer patients, say, than my colleague down the street who's seeing far more per day than I would ever want to because I wouldn't be able to build that relationship with them. Having said all that, what I would say is, make it clear up front of that appointment that you're coming in and you want to discuss this, whether it's by a phone call to that doctor's staff member, their nurse has to speak directly with the team for that doctor and say, look, I know that, I saw my blood work came back. I know what I'm coming in to talk about, and I'm very concerned about my PSA being elevated, and I want to make sure that in preparation for that visit that the doctor's aware that that's something I want to spend some time with. Writing down your questions, before you come in, because obviously you're going to forget, once you're in the room and you realize you have the pressure of that few minutes with them and, it's like any of us, we freeze. Having your questions written down, and not 40 of them because then the doctor's going to be like, okay. But three poignant questions that are going to get to the heart of the matter. it's always okay to do some research ahead. Just like I said with the Dr. Google thing, be careful because not everything you read out there is correct or accurate. But at least having some base to jump off of on the, with the conversation. But I think preparatory phase, thank you, your doctor for that visit, because I appreciate that when I know a patient of mine's coming in and they've called ahead. Saturday afternoon, and then I
retain that information, because I know for a lot of folks it can be a little bit intimidating to try and listen to that terminology and understand it, and then
And I'm talking and discussing with the patient what the problem is and what I would do. And he's giving me his feedback, but I think somebody with you, two sets of ears, is a great way to go about that.
do most of you bring significant others when you go to doctor's appointments? Yeah. I do too. Any other questions?
Other than price and the rabbit hole, what is the downside to having additional blood tests, non-invasive tests like that? You know, there's lots of things they can test for. So, and yet I know we don't, because the chart has 5 million check boxes.
Right.
5 of them get checked off.
Exactly.
But what is the downside other than price and possibly going down the rabbit hole? Because if you're the one
Right.
that something is caught, it just seems like it's worth a little extra cost.
Absolutely. Are you speaking specifically about PSA tests or just in general?
Just in general.
Just in general?
It's about many different things. PSA is just one of them.
Okay. That's a great question. Really, it is mostly what stems from 70 and even 6 months. I'm good.
Primary care guy, your primary physician, you're
Mhm.
and getting all. Shows you have a prostate cancer.